Hello, everybody. Welcome to the world of Cushing syndrome. Today, I have compiled so many interesting explanations to the clinical manifestations of Cushing syndrome. And as usual, there will be a lovely medical mnemonic. So, not wasting much time, let's get started. So, in this diagram, we see the hypothalamus with the corticotropic releasing hormone right here on the right. This hormone is made from the paraventricular nucleus in the hypothalamus, and this stimulates the release of adrenocorticotropic hormone from the pituitary gland. I will be referring to this as ACTH. ACTH in turn regulates the release of cortisol from the suprarenal gland, as well as weak androgens from there as well. It's important to remember that whenever there is an increase in the cortisol levels, there is going to be a feedback mechanism, which is going to be a negative feedback. And that's going to serve to reduce the corticotropic releasing hormone, which in turn would like to reduce the ACTH and to regulate the level of cortisol that is being produced. Now, we can call this the hypothalamus pituitary adrenal axis. And how does it release the cortisol, the hormone of subject that we are interested in today in Cushing syndrome? So, cortisol is made from this zone here called the zona fasciculator. This zone is in the adrenal cortex. So, what I've represented here, zona glomerulosa, zona fasciculator, as well as zona radicularis, they are all in the adrenal cortex here. But the specific part that is responsible for the synthesis of cortisol is the zona fasciculator. So this is where ACTH comes in here and stimulates certain receptors here. Through G protein coupled receptors, there is a production of cortisol. Now, we've also said that ACTH can also stimulate receptors in the zona radicularis here and also cause a release of weak androgens as well. Now, when I was a medical student, there was a way that I used to memorize which of these zones produce which hormones. So I would write GFR. Okay, GFR is simply glomerular filtration rate. Then I would write ACS, which is acute coronary syndrome, and I'll map that. When I map that, what I have is that the zona glomerulosa produces aldosterone, the zona fasciculator produces cortisol, and the reticulary zone produces the sex hormones. I think it's an easy way to memorize which zones produces which hormones. And of course, we have the adrenal medulla here, which serves to bring out the catecholamines as well. All right, so let's recall together that the hypothalamus pituitary adrenal axis works by the circadian rhythm, meaning cortisol activity is highest in the morning and lowest at night. And how does ACTH regulate the synthesis of cortisol from the zona fasciculator? It does that by increasing the activity of cholesterol desmolase enzyme. This enzyme helps in the conversion of cholesterol into pregnenolone, which is a substrate for making cortisol. Now, if we have a patient or any individual with an increased level of cortisol, there should be a negative feedback mechanism that will seek to decrease the corticotropic releasing hormone from the hypothalamus. This in turn should decrease the level of ACTH, and that will cause cholesterol desmolase activity to decline. There will be less formation of pregnenolone and of course a subsequent less formation of cortisol. So this is a rate limiting reaction, and this is how ACTH controls the formation of cortisol. We can also recall that cortisol circulates mostly in an inactive form, and they are usually bound to corticosteroid binding globulins or albumins. Now let's discuss a bit of physiology and how we can relate this to the pathology. Cortisol is a catabolic hormone that breaks down proteins as well as lipids. The process of breaking down the proteins is called proteolysis. You do recall that proteins are made up of amino acids and nitrogenous compounds. If you break them down, you would release those amino acids into the blood. So the amino acids, some of them are glucogenic, meaning that the liver can pick them up and use them to make glucose, a process we call gluconeogenesis. So excessive cortisol levels increases gluconeogenesis, and that will lead to an increased glucose levels in the blood. Simultaneously, cortisol is able to inhibit insulin production or synthesis from the beta islet cells and also increase the production of glucagon from the alpha cells. This would lead to a low glucose uptake. You do recall that insulin helps the glucose to be picked up by the cells. Now that it is inhibited, the glucose is going to be stuck in the blood, and that is going to lead to a glucose intolerance or a diabetes mellitus. Now we can conclude that this predisposes the Cushing syndrome patient to diabetes mellitus, and this has a prevalence of about 20%. On the other hand, cortisol is able to break down the lipids, a process we call lipolysis. There is formation of free fatty acids. These free fatty acids can be used in beta oxidation as energy source for other cells. This process can even lead to ketogenesis and metabolic acidosis. Now, in part, there is also the formation of glycerol, which is also used by the liver to make glucose, in other words, gluconeogenesis. And this also increases the risk of having diabetes mellitus. Cortisol also enhances their activity of catecholamines as well. Now, it's important to state that cortisol's effect on lipids is not exclusively lipolysis. For simplicity's sake, you have to take it like that. But if you are very curious, you will see that people with Cushing syndrome have truncal obesity. This is because of redistribution of fats in certain areas of the body. It's been shown that cortisol rather increases the fatty tissues in the visceral parts of the body. And so it's not exclusively lipolysis, but there is also adipogenesis in the inside of the abdomen as well as the back of the neck and even the face. So, how does cortisol affect the immune system? It suppresses antibody formation from B cells, potentiates apoptosis of T cells, inhibits the migration of neutrophils to inflammatory sites. Clinically, we have said that patients with Cushing syndrome are susceptible to infections, or they might even have severe infections, poor wound healing, and ulcerations, all due to the immune suppressive nature of cortisol. So, patients with Cushing syndrome may develop a high blood pressure due to the mineralocorticoid effect that cortisol possesses. Majority of corticosteroids circulates in the inactive form. Cortisone is the inactive hormone that can be converted into cortisol, which is the active hormone. This is done by 11 beta hydroxysteroid dehydrogenase 1. Cortisol can also be inactivated into cortisone by 11 beta hydroxydehydrogenase 2 enzyme. Now, in this case, we have a patient with Cushing syndrome. There is excessive cortisol, so the cortisol is able to stimulate mineralocorticoid receptors. If you do recall, these receptors are originally meant for aldosterone. When aldosterone binds to these receptors, there is sodium water retention that leads to volume expansion and an increase in the blood pressure. So cortisol is also able to do that in Cushing syndrome by activating these mineralocorticoid receptors, retaining the sodium as well as the water and increasing the blood pressure. When these receptors are activated, it also leads to a decline in the potassium levels in the blood. Co-androgenic secretion. Certain adrenal gland tumors may produce androgens as well as cortisol. ACTH is also able to stimulate the zona reticularis part of the adrenal cortex and release weak androgens. The effect can be hirsutism or acne. Some of these weak androgens undergoes aromatization with the formation of estrons and gynecomastia in certain patients with Cushing syndrome. So patients with Cushing syndrome, specifically those ones that result from elevated ACTH levels, whether being Cushing's disease or ectopic release of ACTH, may develop hyperpigmentation. This is probably due to the fact that ACTH levels are able to stimulate melanocortin 1 receptors and lead to pigmentations. Another explanation is that melanocyte stimulating hormone is a byproduct when ACTH is being produced. and this hormone is also able to influence pigmentations. Patients with bilateral adrenalectomy may develop pigmentation, for example, in Nelson's syndrome. Bones. So the catabolic effect stimulates bone osteoclastic activity over bone formation, which leads to osteoporosis or osteopenia. Cortisol, aka the stress hormone, affects the central nervous system in numerous ways. It gets elevated in stressful situations where there is a fight or flight. This may lead to functional impairment of the hippocampus, the amygdala, as well as the hypothalamus pituitary adrenal axis. These structures are specialized in learning, memory, as well as emotional handling. So there is a sympathetic nervous system activation because cortisol enhances that catecholamine effect. There can be a high heart rate or even cardiovascular events. Patients may complain of depression or even psychosis as a result of the derangement of even some neuromediators in the central nervous system. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.